Hello, my name's Karen Ford. I'm Senior Lecturer and Non-Medical Prescribing Lead at De Montfort University. We're going to look at prescribing in practice. That's part one presentation today. As you can see from the learning objectives, the aim of this session is to point out some principles of good prescribing practice, trying to highlight the legal requirements and emphasising that this is a legal position that you're placed upon as a prescriber, looking at what's legal and what's good practice, around fraud issues when you're a prescriber and writing prescription, and also to explore how you might feel with the prospect of becoming a prescriber with this new extended role. So the facts: nurses have been prescribing for a long while now, around 9 years, and that's grown and evolved over that time. I started prescribing in 2003, so I've seen it really right through from the beginning. Research by Latter showed that 93% of nurse prescribers and 80% of pharmacist prescribers were actually using their qualifications. Earlier research showed that there was a problem with people being confident to actually prescribe, but that's changed now. The research from 2010 from Latter et al. Supports that, which is really good news for prescribing and for patients particularly. And patients in Latter's research were very supportive and accepting of other people besides doctors or dentists prescribing for them, so both nurses, midwives and other allied health professionals as well. So a very positive response to the research. There's still problems with prescribing errors, and these can happen at different stages along the pathway of a prescription. So if you think about people you may have seen prescribing, think about where these errors might occur. It can be down to just, people often think when you think about prescription errors, they think about the actual prescription and the dosage or the name of the drug or the right drug for the right condition. But it's bigger than that. It can be making the incorrect diagnosis. It can be in terms of not considering a differential diagnosis and getting all the information. Have you listened to your patient? Have you actually taken the time to make sure you have all the information and ask the right questions? So that is absolutely critical and can lead to errors if it's not done correctly. It can be to do with the actual writing of the prescription, not to do with the actual drug and dosage, but legibility. It can be to do with poor communication within the team, not understanding what someone previously has suggested or been prescribed if you're prescribing a repeat prescription, for example. So lots of issues. If you're taking a patient in from the community into hospital and you're transcribing what they've been prescribed before, errors there. So along the chain there's lots of opportunities for errors to occur. Hospital prescribing errors occur for about up to 9.9% of all prescriptions, so from Dean's research, so that's quite high, and something we can do something about. The things we're going to talk about really, if we get it right, there shouldn't be prescription errors. So with those sort of thoughts in mind, why do errors occur? Well, sometimes it's unintentional. We're human, we do make mistakes. Sometimes it's through omission. It can be not knowing all the facts, as we've said, in terms of assessment, but also just not having the knowledge, not consulting sources of evidence to support prescribing decisions. So that can be through omission, prescribing something that's not recommended or appropriate. So there's lots of areas where errors can occur. We've said about briefly about illegible prescriptions, but that is so important. If you look at the legal requirements in the BNF, legibility is key, and to write in a black pen for all prescriptions as well if you're handwriting them. Things going down to actually the content of the prescription, it can be around things like using decimal point or zeros. They are very common, particularly decimal points and tenfold errors, which are very common, and particularly in paediatric prescribing. Being distracted. When you're in the quiet of your home, if you're studying and you're writing a prescription to present to someone to be marked, or if you are practicing in the classroom, which you may do after these lectures, you have the luxury of being able to completely concentrate and take your time what you're going to prescribe. But that's not the case in practice. You'll be in a situation where you may be in a busy ward, there may be relatives talking at you, other people demanding your attention, you may be in the home, carers, children of relatives, all sorts of people still asking you questions even though you're trying to concentrate, write the prescription, consult your BNF, etc. So distractions are a very big factor, and that's something that's very important to bear in mind when you are in practice writing. Dean's research, which we've already referred to in 2002, also showed that doctors didn't regard the task of prescription writing as important, but I think for nurses, midwives and AHPs, we want to make that clear that it is a really critical task that you must get right, and this is where it's the crux of where many errors occur at the prescription writing stage as well, so it is important that we get it right. Computer generated prescriptions are great because they can overcome a lot of the problems that handwritten prescriptions can lead you into. For computer generated prescriptions, you've got the advantage of having it linked into messages that come up to say, maybe consider this as an alternative, a generic option, what the first line options are, etc. So it's a great thing if you are able to access computer generated prescriptions. I can tell you of an example where someone who's now a qualified prescriber was used to generating their own electronic prescriptions and merrily doing this in her practice as a nurse practitioner in the community. And then one day she found a fault with the prescription generation, fault with the computer, and had to handwrite her prescriptions again, and found this very, very hard because she got out of the practice of handwriting, had to really think, and it slowed her down and was a real challenge again to get it right because she'd just become to rely heavily on electronic prescriptions. So it's something to consider, if those of you that have the luxury of electronic prescriptions, can this cause risk in terms of when you may have to write a hand prescription? So it's probably good to occasionally write one by hand to keep your skills up, and so that when you do need to do it for a situation just like I've described, that you're competent to do so. And another thing to say, because you're generating an electronic prescription, don't assume what's on there is correct. It's still good practice to quickly scan, check all the information is correct, and then sign. I have heard of cases where students of mine have been observing prescribers and they're pulling the prescription out of the printer without casting a second glance at it and signing it, handing it to the patient. I think it's very good practice if you actually check and read through again, and if it's incorrect, tear it up and generate a new one. Better to be safe. So, with these scary thoughts in mind, how do you feel about prescribing? Does it fill you with trepidation, which I think it probably should do? I think that's healthy. I think it's important that if you've looked at all the implications of prescribing, you consider your own accountability within prescribing, and you are aware that not to be pushed into prescribing if you don't feel comfortable and it's outside or borderline outside your area of competence. That's absolutely key. And it can be difficult for some of you, particularly if you're employed, for example, in general practice. You may feel an obligation that your employer is asking you to run clinics that you don't feel competent to in terms of generating a prescription. So you need to think of your own professional code of conduct there and saying no if you don't feel comfortable. It may make you feel that you don't ever want to write a prescription when you hear all around the legal issues and the complexities of writing it. And for a lot of my students say that until they actually come to physically write it, they think, oh yes, I can do it. And even those that have written them before and the doctors have signed, particularly in the community setting, that's been the old custom and practice, to actually know that they're accountable is a different feeling altogether, and it's quite hard to actually get the prescription right, they find, to start with, and they're very nervous, and that's very natural. And I think to acknowledge those feelings is important. Think about, do you need to prescribe? Do you always need to prescribe? Because you have a prescription pad, does that mean you should prescribe? And I think that's a very important message, that you should always consider, do I need to prescribe in this situation? Is there an alternative? Am I competent to prescribe? Should I refer on to somebody else that is competent? And think about your patients. Will it benefit them for you prescribing for them? If you can't see a benefit for it, why should you put yourself in that position? Think about the conflicts and issues you may have to address by going into this new role. People within the team, peers, patients who may not expect you to have this extended role. So quite a lot of things to think about, and think about how you feel about all these different issues. And obviously you may have other things that you can think of from your own individual area of practice.